Yeah, thank you very much for inviting me to speak today. I'm going to talk about a piece of work which we conducted in the Older People and Frailty Policy Research Unit, which is a collaboration between University of Manchester, Newcastle University and LSE. And we did this piece of work in partnership with the Epicentre with colleagues based at UCL and with people at University of York. So it wasn't quite a cast of thousands, but it was almost. So I'm going to give you a bit of context first, then talk about the main findings. I'm not going to go into a load of methods. And then I want to put the findings in the context of COVID-19 and give you a bit of food for thought. So at the beginning of the pandemic, when people over 70 were strongly advised to stay at home, the government put out a call for NHS volunteers, which you may well remember. And one of the tasks they wanted them to do was make telephone calls to isolated older adults. And whilst this was quite a positive move, we did have concerns about how that would be delivered. And I wear another hat, which is that I'm chair of the board of Age UK Calderdale and Kirklees in West Yorkshire. So I know that befriending and other community support services usually have a lot of systems and processes in place to support the volunteers who are delivering the support, as well as those receiving the support. And at that time in March, many of our support services that had previously been delivered face-to-face had to switch very quickly to remote delivery. And as an organisation, we were providing support and training for staff members to manage that transition to more remote and online service provision. So we did have some worries about how the NHS volunteers would be trained and supported, and suspected that perhaps they wouldn't be. So we approached the Department of Health and Social Care and proposed a rapid evidence review to look at remotely delivered befriending, social support and low intensity psychosocial interventions, which were aiming to address loneliness or social isolation. And they put us in touch with others who were working in the same area, which is how we came to work with the Epicentre and people in York. And we worked together with a view to recommending how remotely delivered support services should be structured. So before I say any more about what we did, it's important to be clear what we're talking about. So loneliness is an emotional response where there's a deficit between the relationships and social engagement that someone wants to have and what they actually have. Whereas social isolation is a concept that reflects the number of social contacts that someone has. And social networks of socially isolated people tend to include few people with infrequent, meaningful contacts. So you can be lonely, but not isolated, and vice versa. And to give you a real example of my dad, who's 85, he's extremely well connected, but he's desperately lonely. He's got friends in the street where he lives, he's got friends in the church, friends through family and from playing bowls. And when you talk to him, he's very jolly and he appears to be doing okay, but when he goes home, he's desperately lonely because my mum's no longer there. So an intervention to increase the number of his contacts wouldn't work to address his loneliness. And obviously the pandemic has made the situation much worse for him and for so many older adults who already have more risk factors for loneliness and social isolation. So just briefly then with the research findings, just a tiny bit of methods. We had a very robust search strategy and we found 5 reviews with 18 primary studies that met our criteria. We conducted a narrative synthesis of the findings, as well as 2 processes called intervention component analysis and qualitative comparative analysis to understand the ways in which the interventions were effective. So these 2 are formal processes that understand how interventions work, looking at what are the components that contribute to success. ICA is used to identify and extract evidence on the core processes that are at work, whereas QCA uses theory to identify which outcomes, for example, decreases in loneliness, are associated with which conditions, for example, connecting people who have a shared experience. So a disclaimer, don't ask me any questions in the Q&A about these 2 processes because those were done by my colleague at UCL. The 5 reviews looked at the relationship between technologies used for communication and social relationships, psychological well-being, social isolation, and social connections. So what did we find? So from the narrative synthesis, we found that supported video communication interventions were regarded positively by older adults, with evidence of decreases in feelings of loneliness and increases in social support scores. Telephone contact was used in only 2 studies, but qualitative findings showed reduced feelings of loneliness and social isolation, with older adults feeling more connected to others and feeling more able to cope. Online discussion groups and forums showed mixed results, with some increases in social support, but limited reductions in loneliness. 4 studies didn't measure loneliness at all. Social networking sites have the potential to reduce loneliness in older adults, but the evidence here was weak. Older adults appear to value fewer, stronger connections with others on these sites, as opposed to many weaker ties, so perhaps had fewer Facebook friends than their grandchildren. Multi-tool interventions, by which we mean providing a PC, giving training, and then the availability of messaging and chat groups. These demonstrated significant decreases in loneliness, but not always increases in social support. But the nature and content of those interventions did vary a lot, so it's difficult to isolate which elements were effective. And also the concepts of loneliness and social isolation did vary between studies, making comparisons and conclusions challenging. I've used certain definitions at the start of this presentation, but not everybody uses the same ones. So from the ICA and QCA, those processes helped us to identify some key characteristics of the interventions which were effective when developing social support. So firstly, supporting the development of close relationships where participants can express their feelings freely and without self-consciousness through unstructured discussions with people like them. Supporting interactions through ensuring participants share experiences or characteristics, for example, being a carer, being a stroke survivor, women only, or people of similar age or social economic status. And also supporting interactions through what we call pastoral guidance. And for an example of that is a light touch oversight of a discussion forum by professionals, or opportunities for participants to contact professionals for advice. Successful interventions tended to ensure that all 3 of these characteristics were in place. There were other processes which we think might be important, as they were more frequently observed in the successful interventions. So ensuring that participants feel their involvement is beneficial for others as well as themselves, that they have a stake in the intervention design or the way they can participate, and that they can communicate through different channels and temporalities, so real-time and asynchronous chat. And taken together, we think these can serve as design principles for future interventions. So overall, the results suggest that older adults can be empowered to support each other through online discussions and forums. And we should really challenge the assumption that older adults always need to be on the receiving end of an intervention to address social isolation and loneliness. Studies that enabled older adults to feel their contributions could improve the outcomes of others tended to be successful. So recognising that older adults can be both providers and recipients of support simultaneously is likely to be an important design principle. It's important to say something about the support that was available to older adults in these studies. They had feelings of apprehension, fear of getting things wrong, and a lack of digital skills, the same as we find with a lot of older people. And support was available from either research staff, carers, or health professionals to deal with any technical issues quickly. And this reduced the likelihood of people giving up on the technology for sure. However, it's important to say that the support in these studies was in the background, so they weren't sitting alongside somebody. So they didn't get in the way of people forming and maintaining relationships with their peers or with family members. Help could be called upon when it was needed. And in some of the cases, the studies that were run in care homes, it was literally somebody in the corridor who could be shouted if the screen froze or if they made something disappear. But what about access to digital tools? So the reviews that we included and others that we know have do have a preoccupation with delivering interventions through digital technologies. And this is problematic and inequitable when we know that 77% of people aged 70 plus have low levels of digital engagement. And in the Lloyds Bank Consumer Digital Index report from last year, their results show that there are 48% of the population who are currently offline, and that the 48% of the people who are currently offline, there's nothing that would encourage them to go online. And they had similar concerns to the ones we saw in our studies about online safety, lack of digital skills, lack of interest, prohibitive costs, and fear of getting things wrong. And during the COVID pandemic, access to many services has moved online, creating and exacerbating inequalities. It's become difficult for people who don't have access to digital technologies to be full citizens when there's a digital first policy within services. Difficulties with shopping, paying bills, accessing health services, connecting with friends and family. These have all been experienced by those who are not online. There are some good examples of successful projects to reduce digital exclusion across the UK. The Good Things Foundation and our own local Age UK's Get Connected, Stay Connected initiatives, which both provide devices, data packages, doorstep setup and training and ongoing support to use the internet, but they won't reach everyone. So here's my plea, don't forget the telephone. I've made a couple of suggestions here because I would argue that the options are not either face-to-face or online. There's still a place for the telephone. The characteristics of successful interventions that we found in our review applied just as well for services and support delivered through the telephone. So telephone befriending services, for example, can still connect people with shared experiences and interests so that close relationships can develop. And we can still underpin that support with access to information, advice and support from professionals when it's needed. So thanks very much for the invitation. Thanks for listening. I've included some links in my presentation, which I think can be shared to my own email, Dylan Neal at UCL, who I worked very closely with, the link to the full report and the published review. So thanks very much.